look at the group 3, almost all the patients whom we've detected of having a palpable liver was found to have evidence of possible non-alcoholic steatohepatitis. And here in the first group, again, more than half of the patients who had clinical evidence of palpable liver seems to have evidence of non-alcoholic steatohepatitis. So what the inference we gathered from here is clinical detection has a very good place in determination of fatty liver disease. What are the comorbidities and what is its prevalence? So it is highlighted here that we studied 4 conditions: type 2 diabetes mellitus, hypertension, coronary vascular disease, and osteoarthritis. All 4 conditions were seen mainly in the extreme obese, morbid obesity group. However, diabetes and hypertension was again prevalent in the upper healthy weight group here. The rest of the other groups also had significant involvement of diabetes and hypertension. There is presence of osteoarthritis throughout all 5 groups, but its involvement is greater with increasing body weight. So with this smaller study, we have come to following conclusions. According to WHO data, we all know that the adulthood obesity has increased from 12% to 24% over last 10 years. And overweight and obesity trends in this studied Sri Lankan urban population shows alarming health concerns. And married middle-income group females with more than 2 children have higher risk of overweight-related problems. Metabolic syndrome and non-alcoholic steatohepatitis is significantly present even in upper healthy weight group, that is BMI between 23 to 24.9. Type 2 diabetes and hypertension. These are 2 major cardiovascular risk factors, and it was significantly seen in all 4 groups of patients. And definitely this would have affected and added a significant burden to our healthcare system. We recognize a couple of limitations to our study. In fact, you all have already noticed that the total study population was small. It automatically gave rise to smaller subgroups. And also we have our study has mainly focused hospitalized sick patients. So how applicable this to the overall community was a question. And also we could not confirm non-alcoholic steatohepatitis histologically due to hospital policies. So with this limitation, still I would like to bring these suggestions to you all. It is the responsibility of all healthcare workers to detect weight gain and weight-related diseases as early as possible and promote health education on prevention of overweight and obesity, and treat comorbidities appropriately to reduce morbidity and mortality among obese individuals, and we definitely need further community-based studies. So these are a few references I used to prepare this study, and I would like to highlight the authors. Especially my thanks should go to my trainer, Dr. Wijesundere. I would like to express my thanks to her, and lastly I would like to highlight that it is the time has come for us to take the biggest step to maintain a very good weight and a good healthy life. Thank you very much.
Yeah, thank you, Dr. Jayawickrama, for that interesting presentation, and paper is open for discussion. Could I just add that one more limitation under the list that you included? Your age range was quite vast, isn't it? It was 18 to 83. And I don't think you can make many conclusions when you are dealing with such a big age range, because the disease prevalence and the comorbidities, they significantly differ in that age range. So I suggest that when you take this study to community next time, you look at a specific age range, maybe middle age or something like that.
Yeah, that's a good suggestion. So in fact, we realized, because our initial decision was to include all the patients admitted to the ward, and in fact the study was stopped little earlier because of practical reasons, because there was a dengue epidemic and we had to actually more concentrate on more seriously sick patients. So age range we could not actually specify further. We did not. That is actually one of the limitations I mentioned. Yes.
Well, this is the problem is actually if you get the transaminases elevated, and then then the problem is that patient's alcohol history, and if patients say I don't touch alcohol, then there's no question about it. But the moment say patient I take alcohol every now and then the question is whether we are dealing with alcoholic hepatitis or we are dealing non-alcoholic hepatitis. So I don't think anyone knows the answer, and then you have to fall back on histology.
Criteria are the most suitable. You elevated liver enzymes, evidence from the ultrasound scan, as well as if you can confirm it histologically, that's the ideal, because then you know where you stand really. Because there are many other causes, especially in our country, use of substances like Ayurvedic medications indirectly can give rise to elevated liver enzymes as well as cirrhotic changes. So you can't conclude the diagnosis of NASH really without having histological evidence.
How did you estimate osteoarthritis?
It's clinical diagnosis, basically clinical diagnosis.
Yeah, which can be a problem. Yeah, because if you ask someone has got pain in the knee, most of the people will say yes.
We didn't actually question because the diagnosis of comorbidities was through the history, not at this occasion, and also most of them has had previous diagnosis related to coming with the previous diagnosis of comorbidities.
Okay. All right. Okay, in the absence of further questions, thank you very much for that lovely presentation. Thank you.